Hi, my name's Eric Gratias, and I'm Chief Medical Officer at eviCore Healthcare. I practiced as a pediatric hematologist-oncologist, which is a physician who specializes in the care of children with cancer and blood disorders. I practiced for 9 years after completing my fellowship training. I wore a lot of hats during that time. I was medical director for our clinical lab. I led the committee that reviewed research activities for our local hospital. I was a teacher of pediatric residents and medical students, and I was very actively involved in international and national research efforts on pediatric kidney tumors, specifically a tumor called Wilms tumor. I made the decision to come to eviCore in 2013. A company called Med Solutions was looking for a pediatric oncologist to join their team, and were needing to add someone with that clinical background to help write their guidelines for advanced imaging in pediatric cancer patients. And frankly, I was very intrigued by that. Learned through experience that to solve problems on a scale like this, you really need a team of experts from a lot of different stakeholder groups and a lot of different disciplines. And these problems are complex and can't be solved by any one group. And that includes physicians. Physicians need to participate actively in improving the healthcare system. And I thought that was a really neat opportunity to have a bigger impact on positive change in American healthcare. I think one of the biggest impacts that I'm able to have through my work at eviCore is through the creation and maintenance of really the highest quality evidence-based guidelines. Specifically, one thing that used to frustrate me in practice was when I would have patients that would come to me too late. There were delays in diagnosis, and one of the areas that was really common was in pediatric brain tumors. And we went through a time where the request from the system was to work your way upward in terms of costs. So start with lower cost studies and work your way up. So for advanced imaging of a child, that might include starting with a CT scan and then moving on to an MRI. That doesn't sound like much of a big step, but that can really cause a delay in care, because for pediatric brain tumors, roughly 60% of them occur in the back half of the cranial vault. And that area is not very well seen on CT scan in young children. I was able to write into the guidelines really what is the standard of care, which is, if you're really concerned about the possibility of a brain tumor in a young child, start with an MRI. It will reduce your time to diagnosis. It will give you a more definitive answer. And you're saving the cost of an unnecessary CT. I had a peer-to-peer with a pediatrician very shortly after we put these guidelines into place, and the pediatrician was rather frustrated that we had not approved his request for a CT. And in speaking with him, once he realized we weren't saying don't image the patient, we were saying there's a better way. Use the MRI first. He was shocked. He said, "You'll give me an MRI now?" I said, "Yeah, absolutely." I said, "What are you going to do if you get a CT scan that doesn't show anything?" He said, "Well, I'm not going to trust it. I'm going to need an MRI." I said, "What are you going to do if you get a CT that finds a tumor?" He goes, "I'm going to need a better definition, so I'm going to get the MRI." So regardless of the result of the CT scan, the MRI was going to be necessary. And so he was extremely grateful for my intervention to speed up the diagnostic process. And for me, the cool part is he's going to carry that forward in his practice. We can help providers practice better medicine by filling in those little inevitable blind spots that creep in the evidence and empowering them to do their critical work of providing just the very best patient care that's possible.